on compartment syndrome.
Please, I think that would be very helpful.
Yes, thank you. Let's talk about another orthopedic emergency, just a few slides, as the compartment syndrome. As I think Edward mentioned some of the case shows some of the photos. An acute compartment syndrome is a potentially devastating complication, as said Edward previously, associated with a fracture, this is characterized by increased pressure within a closed muscle compartment, leading to an impaired circulation, muscle and nerve ischemia, and if left untreated, the compartment syndrome create irreversible tissue damage, contractures, and or even limb amputation, according to this paper from 2025, acute compartment syndrome in tibia fracture, which was a meta-analysis. The causes of increased pressure, it's just from the trauma, where we have bleeding, you have edema of the muscle or muscle swelling, and the perfusion injury, with an effect of reducing capillary perfusion to the tissue, and which cause ischemia and necrosis. The compartment syndrome diagnosis, this is a clinical high index of suspicion in trauma, mainly in fractures and mainly in open fractures. Any injury ranging from high energy open fracture to lower energy crush without fractures, you may have high index of suspicion of compartment syndrome. Even a prolonged pressure upon a compartment can create a compartment syndrome. On a physical examination, as I said previously, you have 6 P's, where you have a pain which is out of proportion, which is the pain more than the pain you had at the level of the injury, and all on a physical examination, especially with a passive stretch of the affected limb, where you could have a severe pain. You can have paresthesia, we said, which is very late, pulselessness, very late also, and the paralysis, very, if you have this paralysis, post-trauma, post-injury, then this is a late phase of compartment syndrome. The treatment of compartment syndrome is said previously, Edward. This is a fasciotomy. The indication, this should be not based on those parameters, should be a clinical high index of suspicion. Where you have the compartment pressure should be more than 30 to 45, and the prophylactic ischemia injury, if it delays more than 4 hours. High clinical suspicion. Approach similar to appendectomy. This is an old statement where you will never feel bad for doing fasciotomy. You will never regret doing it, but you will only regret not doing it if you didn't do it. If you have a high index of suspicion, we don't have those measures, do fasciotomy. And there's fasciotomy said, Edward, never perform an incomplete fasciotomy. Like this with this picture, this is a disaster of doing the fasciotomy. You must completely release compartment, regardless of location. Never close the skin, and if the compartment is more than 24 to 36 hours, it is too late. There is high risk of infection, high risk of amputation, and high risk of death. That is why once a diagnosis, you act, and you act as you should never perform an incomplete you have to complete release all the compartment. I think this was the end. Thank you very much.
That was excellent, Joel. Thank you.
Thank you.
So, guys, what is compartment syndrome exactly? Is it a dysvascular limb? What's the difference? If the pressure in a compartment syndrome, compartment pressure is only 30 millimeters of mercury, but our pulse pressure is 120. What's going on? Where is the ischemia happening? Any ideas? It's capillary beds, right? The capillary beds are ischemic. And that's why you have pain with passive motion. You have ischemia of the muscles. And so if you're moving the tendons and pulling on the muscles, that's what causes excruciating pain. All right? If you wait for the compartment pressures to increase, for the pulses to go away, then it's an ischemic limb. Then it's way too late. Everything's dead already, right? So pain out of proportion. The patient keeps saying, I'm in pain, I'm in pain, I'm in pain. Keeps asking for pain medications. You keep getting more and more pain medications. Think about compartment syndrome, okay? You go and examine the patient, they have a tibia fracture. You wiggle their toes. They scream in pain. Pain with passive motion. These are the sensitive findings that you should be thinking about, okay? Doesn't only happen when you have a fracture. Although, anybody here know what the percentage of patients with a segmental tibia fracture will have compartment syndrome? Any ideas? Who thinks it's 10%? Who thinks it's 20%? Should I go up or down?
I think you should clarify whether these are open or closed.
Closed segmental tibia fracture. What percentage will have compartment syndrome? Who thinks it's higher or lower than 20%? Higher? You think it's higher? Who thinks it's lower than 20%? Okay, we're getting a lot of no votes going on here, but it's 30%. 30% of patients with segmental closed tibia fracture will have compartment syndrome. Okay? And in many cases where we fix a closed tibia fracture, we do prophylactic fasciotomies. Think about that as well in these cases, okay? High energy injuries. Think about doing prophylactic compartment syndrome. All right, Carol, you want to give the last lecture before we move to the coffee break? Excellent. I think it's a really good one. The next lecture will be on debridement. Starting from the beginning, Kieran.
Yeah.